Uh, Today I am going to speak a few words on hepatitis B, its importance, how is it transmitted, and then what is the care that we have to take in general in the public. I know this is a public address program. So actually, why are we worried about hepatitis B? Because of its prevalence and the effects that it causes in the liver. It produces, we all know, cirrhosis and liver cancer. These are the two things why we are afraid of hepatitis B. And our country is a meso-endemic zone, that is, the prevalence is between around 4 to 7% of the population has this infection. 7 persons in 100 population are affected with this virus. So now we are worried because this 7%, out of which 20% might land in cirrhosis of liver, and they can land in liver cancer. So this is what we are looking at. Let us go to the various routes of transmission of this virus. We all know that it is transmitted through blood. So either it can be vertical or horizontal. By vertical we mean it is transmitted from mother to child. So it is early infection that occurs at the time of delivery. And some people get infected at a later age, that is known as horizontal transmission. Usually those people who get infected after the age of 10 years or so, usually it is an acute presentation. They land with fever, jaundice as an acute episode. Usually the good thing about this acute episode is that almost 80 to 90% they clear the virus. So there is no issue of chronicity in this acute hepatitis B. Only 10% or 15% land in chronicity. So we are more worried about this vertical transmission. In India it is more so because of practices at the delivery time and the ignorance of the people in the lower strata. They have this vertical transmission. So this is the volume of the disease and this is the transmission process. Usually it's the blood, as I said. The other things which can carry this transmission are the saliva, semen and sweat, but these are very less when compared with blood. So we need to look at this. The practices of giving injections now it has changed, and then our sexual practices, we shouldn't opt for any multiple sexual partners. It's a high risk individual, these are the high risk groups. Injection edging abusers, especially drug addicts, they are at very high risk to develop hepatitis B infection. So these are the persons which we look into, and also where there is regular blood exchange and there is serum exchange, especially in dialysis patients of chronic kidney disease. That's why for these patients, to prevent hepatitis B infection, we give vaccination. So this is about the various transmission routes. The third thing which I want to actually stress upon is, should we get worried about when somebody has infection? No, because not all the patients develop cirrhosis or liver cancer, because up to 10 to 15% people land in cirrhosis. Now we have to identify those who actually develop the disease from those who are infected. Almost 85% they don't develop the disease. So this is our duty to tell the patients that not to worry about this infection at least. We are worried in those patients who have active chronic hepatitis. So my job is easy now. When the patient comes to me with a hepatitis B report, with a normal ultrasound of the liver, normal liver function test, I am not worried because probably he is in a carrier state, a latent infection. These patients, we have to monitor them properly and see if they develop any activity in the liver without symptoms. That's why we need to monitor but not treat these patients. I see many of the patients, they get really bad on hearing that they are infected. But infection doesn't mean disease. This is the main thing. So what we do is, if a patient is HbA1c positive without any symptoms or signs, we are not worried. We just monitor the patient depending upon the age of the patient, his E antigen status. So we are identifying the type of virus inside the body, whether it's a mutated virus, that is E antigen negative. In India, we see a lot of E antigen negative patients, and these are the patients, they can have a reactivation of the disease. So these patients we need to monitor every 6 months with the help of LFT, and we assure them that you can have normal diet, everything is normal for them, the habits are normal. They don't need to change any of their habits. Treatment is given only when there is an active phase of the disease. That means patients are normal, but they are having elevated levels of liver function test, especially their enzymes. There, we then again test for the viral load, and then if the viral load is high enough to fit into the guidelines that are given by the Indian Society of Study of Liver Diseases, according to that, then we treat them. The main options are two. One is an interferon injections, and then we have so many antiviral drugs, especially the tenofovir, entecavir, which can be given for 4 to 6 years. But remember, antiviral drugs usually they suppress the disease, they don't cure the disease. But this suppression is enough to decrease the incidence of cirrhosis and liver cancer. So this is the goal of the therapy in hepatitis B. We can't cure the disease, but we can control the disease. Now let us see how jaundice can be managed with hepatitis B. There are some things in the society where people go for some practices. Let us talk about those practices which should be avoided, because we find a lot of people have some local practices of taking native medication, and some practices of going for acupuncture or doing some procedures on the skin which are actually not needed. They don't have any relevant data to support. So what I feel that people have to be educated properly that they should avoid taking this native medication in jaundice, which is not a logical thing to do. And also they can avoid practices where they harm themselves with these needles and everything. What the bad thing about using native medication is that we have seen patients, like once they take this native medication, they develop the side effects of the native medication because it induces a lot of vomitings and diarrhea sometimes, and this produces an acute kidney failure. And just imagine the patient is already having a liver failure. Upon that again, the patient has an acute kidney disease. It is quite lethal to the patient. It's very difficult for us to treat once the patient has a drug-induced kidney disease along with the original liver problem. So this is what we see, because we lose time and the patient comes in a very bad state after taking native medication. This is a bad thing. So that's why I just want to suggest that please avoid taking native medication. Second, don't go for any local practices where it is illogical. We have medications, we have nutrition support. So we have to ascertain the patients that to avoid these kind of practices. This is one thing which I want to stress upon, especially in India. And the second thing is, you should avoid those medications which is detrimental to the liver. When you have a doubt that you have a jaundice, you should come to the physician or a gastroenterologist immediately so that you can get a proper diagnosis, whether it is a viral induced or a drug induced. Then the treatment depends upon the cause of the disease. It's easy for the treating doctor as well as the patient also, because the patient is benefited if he comes early to the doctor. So this is what my suggestion is regarding the practices that we do in jaundice, especially more so with hepatitis B. Because hepatitis B is a chronic disease. Sometimes it has flares and then again comes back. You cannot recognize the disease when it is in the sleeping stage. So this is the practices that are to be avoided regarding jaundice and hepatitis B. Next, regarding hepatitis C, it is quite a different disease from when compared with hepatitis B. In India, we see in the last 2 decades the prevalence has increased. Usually we thought hepatitis C is more commonly seen in the West. Now Indian population has started showing more of increasing incidence in hepatitis C because of the practices we have, and more people are going into the maintenance hemodialysis. We see a lot of hepatitis C, spontaneous infections. So the prevalence and incidence has increased in India itself, and there are so many subgenotypes of hepatitis C. In India, most commonly initially we thought genotype 3 is more common. Now the genotype 1 is also increasing in incidence. Now let us see how actually hepatitis C is transmitted, because this is what we were worried. It's more common through the blood. Again, unlike hepatitis B, we see less of vertical transmission, more of blood-borne disease, especially when there is blood contact. Again, it's very commonly seen in drug abusers as well as patients undergoing continuous hemodialysis. These are the two set of patients where hepatitis C is commonly seen, and especially it's more commonly seen in diabetes, where they tend to have diabetic nephropathy, then they land in dialysis. These are the set of patients where they develop hepatitis C. The bad thing about hepatitis C is that the acute phase we miss again. It doesn't present as jaundice or fever. It's very difficult to recognize acute hepatitis C. That's why it goes undiagnosed in the early phase. It's very difficult to diagnose acute hepatitis C unless the patient comes to you that there's some amount of weakness or mild lethargy. Already the patient is on dialysis. Otherwise, it's very difficult to diagnose acute hepatitis C. So more often we see the chronic hepatitis type of C. Once the patient comes to us with hepatitis C, there is nothing like a waiting period unless the patient is a dialysis patient. We immediately have to go to check for his genotype status as well as the viral load, because we need to treat these patients here. In hepatitis C, what happens is there is a standard of therapy. The therapy depends upon the type of virus and the viral load. In genotype 1, it is very difficult to treat because the response to therapy is little less when compared with genotype 2 and 3. But still, there are some guidelines given by our INASL or APASL group where so and so viral load should be there to treat, especially, and all genotype 1 people have to undergo liver biopsy before they are subjected for treatment. Wherein in hepatitis genotype 2 and 3, there is a definite guideline. Short-term interferon with ribavirin combination are the standard of therapy till now. It is given usually for 6 months, and people do respond well. Almost 60 to 80% of the patients respond to therapy. In genotype 1, only 40 to 45% response to therapy is there. So it is very difficult to treat genotype 1, unlike 2 and 3. Once they have full response, we can rest assured that this patient doesn't land into cirrhosis or liver cancer. This is the one good thing. And what you have in the future, recent studies have come where there are new drugs, especially the sofosbuvir, which is given in combination with the earlier treatment, or it can be given solely. Recent studies have come which showed that we don't need to take that interferon injection. We can just go for a oral therapy for minimum period of 2 to 4 years. Still studies have to come, but it's a very good news for the patients of hepatitis C, because now they can avoid sometimes these interferons. But right now the standard of care is interferons and ribavirin. This is very important point. And regarding hepatitis C, once they develop cirrhosis of liver, it's very difficult to treat because there is no particular treatment, because interferons and ribavirin cannot be given once there is stage B and stage C cirrhosis of liver. But there are some studies which show good value when they can be given in the stage A disease or the compensated cirrhosis. But these people develop sometimes very high rate of complications that are related to the injections as well as the disease. So we manage cirrhosis of liver just as any case of cirrhosis of liver, and we don't have any particular treatment once the patient is already having cirrhosis of liver. Again, when it comes to liver cancer, once the liver cancer is there in hepatitis C, same standard of guidelines we follow for the treatment, and we don't treat any hepatitis C, especially once the patient is already having liver cancer. We just think about the liver cancer and treat. This is the usual protocol of management for hepatitis C. The main thing hepatitis C is how to avoid having hepatitis C. The thing is injections, injectables, these are very important. We have to avoid infection through the blood. The second thing is I feel the dialysis machines have to be properly managed, because still we feel that they contract the disease when they are undergoing this maintenance hemodialysis. These are the two things where we can prevent hepatitis C. There is no vaccine for hepatitis C. This is a very sad thing, but we can treat this disease once they are in the hepatitis phase. But once they are in the cirrhosis or liver cancer, again, there is no particular treatment for hepatitis C unless the patient undergoes a transplant. Thank you.